Colorectal cancer. Tumors of the colon and rectum are relatively common. The colorectal area, the colon and rectum combined, is now the third most common site of new cancer cases and deaths. Colorectal cancer is a disease of Western culture. The incidence increases with age. The incidence is highest for people older than 85 years of age and is higher for people with a family history of colon cancer and those with IBD or polyps, irritable bowel disease. Inflammatory bowel disease. The exact cause of colon and rectal cancer is still unknown, but risk factors are increasing age, family history of colon cancer or polyps, previous colon cancer or adenomatous polyps, history of inflammatory bowel disease, high fat, high protein with high intake of beef, low fiber diet, genital cancer or breast cancer in women. The changes in this distribution have been occurred in recent years. The incidence of cancer in the sigmoid and rectal areas has decreased, whereas the incidence of cancer in the colon, ascending and descending colon has increased. Improved screening strategies have helped to reduce the number of deaths in the recent years. Pathophysiology. Cancer of the colon and rectum is predominantly adenocarcinoma, that is arising from the epithelial lining of the intestine. It may start as a benign polyp but may become malignant, invade and destroy normal tissues and extend into surrounding structures. Cancer cells may break away from the primary tumor and spread to the other parts of the body, most often the liver. Clinical manifestations. The symptoms are greatly determined by a location of the cancer, the stage of the disease, and the function of the intestinal segment in which it is located. The most common presenting symptom is a change in bowel habits. The passage of blood in the stools is the second most common symptom. Symptoms may also include unexplained anemia, anorexia, weight loss, and fatigue. The symptoms most commonly associated with the right-sided lesions or dull abdominal pain and melena, that is black tarry stools. The symptoms most commonly associated with left-sided lesions are those associated with obstruction, that is abdominal pain and cramping, narrowing stools, constipation and distension, as well as bright red blood in the stool. Symptoms associated with rectal lesions are tenesmus, that is ineffective, painful straining of stool, rectal pain, the feeling of incomplete evacuation after a bowel movement, alternating constipation and diarrhea and bloody stool. Right-sided lesion means melena, pain, and left-sided lesions, abdominal pain, cramping, narrowing stools, constipation, and bright red blood. Assessment and diagnostic findings. Along with the abdominal and rectal examination, the most important diagnostic procedures for cancer of colon are fecal occult blood testing, barium enema, proctosigmoidoscopy, and colonoscopy. As many as 60% of colorectal cancer cases can be identified by sigmoidoscopy with biopsy or cytology smears. Carcinoembryonic antigen (CEA) studies may also be performed, although CEA may not be a highly reliable indicator in diagnosing colon cancer because not all lesions secrete CEA, that is carcinoembryonic antigen. Studies show that CEA levels are reliable in predicting prognosis. With complex excision of the tumor and elevated levels of CEA should return to normal within 48 hours. Elevations of CEA at a larger date suggest recurrence. Complications. Tumor growth may cause partial or complete bowel obstructions. Excision of the tumor and ulceration into the surrounding blood vessels result in hemorrhage, perforation, abscess formation, peritonitis, sepsis, and shock may occur. Medical management, the patient with symptoms of intestinal obstruction is treated with intravenous fluids and nasogastric suction if there has been significant bleeding. Blood component therapy may be required. Treatment of colorectal cancer depends on the stage of the disease and consists of surgery to remove the tumor, supportive therapy and adjuvant therapy. Data demonstrate delays in tumor recurrence and increases in survival time for patients who receive some of adjuvant therapy, that is chemotherapy, radiation therapy, immunotherapy or multimodality therapy. Adjuvant therapy. The standard adjuvant therapy administered to patients with Duke's class C colon cancer is the 5-fluorouracil plus levamisole regimen. Patients with Duke's class B or C rectal cancer are given 5-fluorouracil and high doses of pelvic irradiation. Mitomycin is also used. Radiation therapy is used before, during and after surgery to shrink the tumor to achieve better results from surgery and to reduce the risk of recurrence. For inoperative or unresectable tumors, irradiation is used to provide significant relief from symptoms. Intracavity and implantable devices are used to deliver radiation to the site. The response to adjuvant therapy varies. Surgical therapy. Surgery is the primary treatment for most common colon and rectal cancers. It may be curative or palliative. Advances in surgical techniques can enable the patient with cancer to have sphincter saving devices that restore continuity of the GI tract. The type of surgery recommended depends upon the location and size of the tumor. Cancers limited to one site can be removed through the colonoscope. Laparoscopic colotomy with polypectomy minimizes the extent of surgery needed in some cases. A laparoscope is used to guide in making an incision into the colon. The tumoral mass is then excised. Use of neodymium laser has proved effective with some lesions as well. Bowel resection is indicated for most cases. Lesions and all class B and C lesions, surgery is sometimes recommended for class D colon cancer. But the goal of surgery is the instance is palliative. Surgical procedures include following: segmental resection, abdominoperineal resection, temporary colostomy, permanent colostomy or ileostomy, construction of the coloanal reservoir called a colonic J pouch is performed in 2 steps. A temporary loop ileostomy is constructed to divert the intestinal flow, and a newly constructed pouch is attached to the anal stump. About 3 months after the initial stage, the ileostomy is reversed and intestinal continuity is restored. The anal sphincter and therefore continence are preserved. So surgical procedures: segmental resection, abdominoperineal resection, temporary colostomy, permanent colostomy, and the construction of coloanal reservoir. Thank you.